Diseases of periodontium. What is a periodontium? The word periodontium, it's actually derived from a Greek word perio meaning around and odonto meaning the tooth. So periodontium is nothing but the apparatus which is surrounding a tooth, and the periodontal apparatus, it includes the gingiva, the cementum, the alveolar bone, and the periodontal ligament surrounding the tooth. So there are a lot of periodontal diseases occurring. They begin as inflammation, that is the gingivitis, and then ultimately they lead to this inflammation leads to loss of alveolar bone and exfoliation of teeth. So if we stop the disease at the gingivitis level, we can save the periodontal apparatus of the tooth and thus maintain the integrity of the tooth. So the gingiva, basically we know it is just divided into marginal gingiva. There is a free marginal gingiva, the attached gingiva which is just attached to the underlying mucosa or bone. So the free gingiva, the attached gingiva, and the interdental papillae, which are characteristically seen between the teeth, that is the interdental regions of the teeth. So in the healthy gingiva, it usually appears the light pinkish or coral pink in color. Whenever there is an inflammation, it appears to be reddened, or it shows shiny appearance. Normally, stippling is seen in the attached gingiva. Children below 5 years do not show any stippling. Okay, that is an exception. But in cases of inflammation, or whenever there is presence of gingivitis, the stip or periodontitis, the stippling is lost and the surface just becomes smooth and shiny. So our oral cavity, the periodontal apparatus, it shows a lot of changes in the inflammation, either the gingivitis or the periodontitis. So the impact of the inflammation on the periodontal apparatus we'll see now. Okay, so what are the diseases of periodontium? The diseases of periodontium are classified according to American Academy of Periodontology 1999 as gingival diseases, which may be the plaque induced or the non-plaque induced diseases, the chronic periodontitis, the localized variety or the generalized variety, the aggressive periodontitis, again the localized variety or the generalized variety, or the periodontitis as a manifestation of a systemic disease. So individual is affected with some systemic disease and he is showing the clinically he is showing a periodontitis. Necrotizing periodontal diseases, it is a group, it includes all the necrotizing diseases, that is a necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis, and necrotizing ulcerative stomatitis also. And there are different abscesses of the periodontium occurring: gingival abscess, periodontal abscess, or the pericoronal abscess. And the periodontitis associated with endodontic lesion, that is endoperio lesion as it is called. And few of the times the periodontal lesions or diseases, they occur because of any deformities or either the congenital or acquired mucogingival defects. Okay, so we'll study the common gingival diseases, the more common periodontal diseases, and the gingival enlargements occurring because of any inflammation or any other etiological factor. Okay, first we'll see the gingival diseases. The plaque induced gingival diseases and non-plaque induced gingival diseases. So more commonly, some etiological factor is present for the inflammation to start in the marginal gingiva. So the plaque induced gingival diseases are more common. The non-plaque induced gingival diseases are gingivitis occurring in absence of any etiological factor like the plaque or calculus. Those are non-plaque gingival induced diseases are the bacterial, viral, or fungal infections which manifest in the gingiva. Okay, what is a plaque? Plaque is nothing but a mineralized deposit seen on the surface of the tooth. It may be due to the accumulation of food debris or due to the accumulation of microorganisms on the surface of this food debris, furtherly leading to calcification of that pellicle, whatever is acquired, the mineralization of that occurs and plaque is formed. Ultimately, the plaque hardens and calculus is formed. The calculus may be a subgingival one or a supragingival one. Both subgingival or supragingival calculus, they are irritating to the gingiva because there is some foreign material is deposited on the surface of the tooth, and when the gingiva normally it's just closely approximated to the neck of the tooth, and there is occurrence of some some material, irritating material, that is the calculus. It just makes the gingiva appear to be loose, and it gets irritated and shows signs of inflammation. Okay, the most common local factor responsible for gingivitis to begin is the microorganisms. We know our oral cavity has a lot of oral microorganisms. It is an inhabitant of oral microorganisms, which are very, very essential for maintenance because they secrete few of the enzymes in the oral cavity. But it is very difficult to make out which microorganisms are useful and which are harmful. But according to others, Actinomycetum comitans is the common inhabitant of oral cavity, and it is the most responsible one for causing this periodontal diseases. Okay. So the microorganisms are causative, and the local factors, as we have discussed, the calculus is the etiological factor. Again, food impaction. Any food which is getting just stuck between the interdental areas or on the surfaces of the teeth just leads to an inhabitat for the accumulation of microorganisms on the surface of teeth. These microorganisms ultimately they just multiply and lead to progression of the disease. Faulty or irritating restoration. Sometimes what happens is in proximal restorations, if the restorative material is just overhanging from the proximal margin, it acts as a source of accumulation of the food debris or the microorganisms, and it just irritates the gingival margin, leading to gingivitis or beginning of inflammation again. Mouth breathers, few of the times what happens is whenever the individual is breathing through his mouth, in case of deviated nasal septum or presence of a lymphoid hyperplasia, so mostly seen in young adults, they breathe through their mouth, leading the exposure of oral cavity leads to dryness of oral cavity. Ultimately, inflammation begins, and microorganisms just catch on this opportunity to start the inflammation. Again, there are all are not born with 100% good occlusion, right? So whenever the teeth are erupted in unusual locations, or they are just malposed or placed out of the physiologic occlusion, and they just tend to adapt to the masticatory apparatus, leading to excessive forces being concentrated on that malposed tooth, thereby disturbing the underlying periodontium. It's also a source of gingival disease. Then the systemic factors, as we have discussed, that nutritional deficiencies, especially the vitamin C deficiency, that is the scorbutic gums, it's manifested in the gingiva. The gingiva become red, swollen, boggy, edematous. So the deficiency of essential vitamins and minerals also manifest changes in gingiva as gingival diseases. And the few of the drugs which have been applied locally, such as aspirin or phenol. Aspirin was previously thought as an obtundant, and it used to be kept locally if there is a toothache. But aspirin being inflammatory in origin, it just used to reduce the pain, but the oral epithelium, whatever is in contact with that aspirin tablet, you just used to get burned. Okay, that's the aspirin burn. So the phenol also has a caustic effect on the oral epithelium. So when used locally, or even when used systemically, like a few of the drugs like anticonvulsants, cyclosporine or immunosuppressants, whenever they were used systemically for treating certain disorders, they showed clinical gingival manifestation of enlargement. So that's because of accumulation of or excessive proliferation of the fibroblasts. That is a different thing, but it is manifested in the gingiva. Then the endocrine changes associated with puberty and pregnancy. We all know that hormone related changes occur at puberty. So both males and females or adolescents, we can say at puberty, they show changes in the levels of hormones, leading to alteration in immune response. So even a mild irritation may lead to development of a severe gingival disease. Similarly, in pregnancy, we get to see the appearance of pregnancy gingivitis more commonly in the first or third trimester. 1 to 3 months of pregnancy, you see that the gingiva, the marginal gingiva, is reddened, swollen, shiny, and inflamed. So that's because of a hypersensitivity response to a mild irritation. That is, a normal calculus may be present, but because of underlying endocrine manifestation, that is the pregnancy, the hormone levels are elevated and it manifests a hypersensitivity response. And few of the gingival diseases may be hereditary, especially the hereditary gingival enlargement. Okay, the acute gingivitis is nothing but of a sudden onset. Gingivitis or marginal gingivitis, which is of a sudden onset, is most commonly seen in cases of acute necrotizing ulcerative gingivitis. We'll study it later on. First, we'll see the commonest of the gingival diseases, that is the chronic gingivitis. Chronic gingivitis is the inflammation of the marginal gingiva. It may also include the interdental papillae and the attached gingiva. The chronic gingivitis manifests over a period of time. Definite etiological factors will be present, either the calculus, plaque, or some other restoration. So the chronic gingivitis inflammation is just limited to the gingiva. Again, the chronic gingivitis may be localized or a generalized one. So whenever the inflammation is just localized to a particular area or a particular portion of the marginal gingiva, it leads to a traumatic or a crescent shaped defect in the gingiva. That is nothing but it is manifested as hyperemia and swelling of the gingiva, marginal gingiva, which is crescent in shape, called as traumatic crescent. So whenever the inflammation begins, initially the color of the gingiva, which is coral pink or light pink in color, it changes to a deeper hue, that is the deeper color of pink. Then ultimately it becomes reddish or reddish blue in color. So the change in color is the first visible sign. Then because of inflammation, there is just the papillae, interdental papillae and the marginal gingiva, they appear to be swollen and there is bleeding from the gingival sulcus. So whenever you insert a periodontal probe into the gingival sulcus, it just manifests bleeding. And because of the swelling of the interdental papillae, they give a bulbous appearance. And as the inflammation progresses, ultimately whenever there is fibrosis of the gingiva as a result of chronic inflammation, and edema and fibrosis both progress, and they lead to accumulation of pus at a later stages also. So that edema and fibrosis, whenever they are occurring in chronic gingivitis, is known as chronic hyperplastic gingivitis. So when you see the microscopic picture of a chronic gingivitis, initially inflammation is present invariably. Inflammation, it shows the presence of characteristic inflammatory cells, that is the lymphocytes, monocytes, and the plasma cells. Okay, the epithelium, it is usually non-keratinized. Here also the epithelium is non-keratinized and irregular. Hyperemia, edema, and hemorrhage of the capillaries are seen, and the capillaries just become enlarged or engorged. That's manifested clinically as the bleeding. And because of increase in number of inflammatory cells, the mast cells, they particularly store certain granules of sulfonated mucopolysaccharides, okay, manifesting the characteristic inflammatory changes. Okay, the epithelium is non-keratinized, there are presence of inflammatory cells, the capillaries are engorged. These are the characteristic manifestations of chronic inflammatory gingivitis. The treatment for chronic gingivitis is nothing but the gingivitis itself is occurring because of some irritation. So if you remove the irritants, the calculus or plaque or irritating restorations, whatever present, if you just remove it, the inflammation regresses to normal even within 48 hours or within a span of few days. Such is the rapidity of depression of inflammation once the etiological factors are removed. As I told, non-plaque induced gingival diseases are a manifestation of bacterial, viral or fungal infections. And the acute form of gingivitis, most commonly it is a specific acute form of gingivitis, that is nothing but the necrotizing ulcerative gingivitis, ANUG, also known as Vincent's infection or trench mouth. What happened was, initially this disease was detected as an epidemic in the soldiers during the World War II. So all the soldiers used to be in close contact with each other, so that led to rapid spread of infection and it became an epidemic. so hence the name trench mouth. Okay, Vincent's infection, it's actually a polymicrobial infection, endogenous polymicrobial infection. It's caused because by a bacteria known as Borrelia vincenti. It is a fusospirochete. It is a very devastating effect on the oral mucosa because it causes necrosis. And the necrotizing diseases have been grouped as necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis also. Okay, so first we'll see the gingivitis form. Initially this begins, what happens, why this necrotizing ulcerative gingivitis begins? It begins of some, it is more commonly seen in individuals who are stressed out. Okay, psychological stress seems to be the predisposing factor. Another is the development of immunosuppression and smoking. Both seem to be the predisposing factor for development of ANAG. ANAG is a very severe gingival disease. It is initially it begins as a hyperemia and edema of the interdental papilla. Once it becomes painful, again it spreads to develop the hyperemia. It just spreads to develop crater-like lesions which are seen in the interdental papilla. Sharply punched out crater-like lesions are seen. So because of the extensive edema, the gingiva shows excessive bleeding when touched or when a probe is inserted. So once the inflammation progresses, it ultimately becomes ulcerated, the epithelium becomes ulcerated and it is covered by a grayish green pseudomembrane. Okay, the clavicular epithelium is non-keratinized only, it becomes ulcerated and it's just covered by a membrane. And because of the microorganisms, the Borrelia vincenti, the individual develops a characteristic malodor, that is a fetid odor. And because of severe gingival pain, the patient will not be able to eat or swallow or masticate food. And the severe gingival pain is one of a pressure. So whenever you touch the gingival surface, the patient complains of severe pain. Okay, and ultimately because of this necrotizing ulcerative gingivitis, it involves the marginal gingiva, interdental papillae, and even the attached gingiva. So the crater-like lesions, whatever are seen in the interdental papillae, that just leads to loss of periodontal attachment. General manifestations include occurrence of malaise, fever and high-grade fever. Excessive salivation is noticed. Regional lymphadenopathy is more common. The individual appears to be very weak because he is malnourished also. Microscopic pictures of acute necrotizing ulcerative gingivitis is entirely non-specific because the surface epithelium, it shows ulceration and it is just covered by a thick fibrinous exudate. The connective tissue, it shows features of inflammatory cells, polymorphonuclear leukocytes, plasma cells. Leukocytes are more common and there is general lack of keratinization. And the demonstration of microorganisms, that is the spirochetes, fusospirochete, Borrelia vincenti, is the diagnostic feature of acute necrotizing ulcerative gingivitis. And what happens is, once the acute necrotizing ulcerative gingivitis is cured, whatever sharp punched out crater-like lesions were present in the interdental papillae, even after healing, the depression of the crater just remains like that, and it acts as a inhabitat or a place for the microorganisms to just persist there. That leads to recurrence of the gingivitis, necrotizing ulcerative gingivitis. Treatment for acute necrotizing ulcerative gingivitis is just symptomatic in nature. The underlying immunosuppression or malnutrition should be corrected, and for symptomatic measures, superficial cleansing of the oral cavity should be done either with a mouthwash or with a chlorhexidine mouthwash, diluted hydrogen peroxide, or even with a warm saline water. And local irritants present should just be removed by scaling and polishing and topical anesthetic. It just decreases the pain and just makes the patient to at least eat something so that the underlying malnourishment is corrected. Okay, that's about the acute necrotizing ulcerative gingivitis. Desquamative gingivitis is another acute form of a gingivitis. It is not a disease actually, it is a condition which is characterized by intense reddening and desquamation of the epithelium is seen. Usually in acute necrotizing ulcerative gingivitis and all, inflammation is there and it's just progressing up to the point of necrosis. But here in desquamative gingivitis, ultimately the epithelium just gets separated from the connective tissue. It's not a disease, it's just a condition. As I said, the etiology for desquamative gingivitis is occurrence of certain dermatosis, that is certain dermatological disorders like the cicatricial pemphigoid, lichen planus and pemphigus are more commonly implicated. Apart from that, the hormonal influences and abnormal responses to irritation or some chronic infections may be the causative factors. Score and Masler, the authors, they denoted that desquamated gingivitis is a specific degenerative disease of the gingival tissues, and they gave the term gingivosis to it. Desquamated gingivitis is actually seen in about middle-aged individuals about 40 to 55 years of age. The clinical appearance of gingiva are one of red and swollen, and multiple vesicles with erosions are seen. Multiple vesicles with erosions of the gingiva are seen, and the exposed bleeding connective tissue surface. The Nikolsky sign is positive here. The Nikolsky sign is nothing but whenever you rub an unaffected epithelial surface, even that epithelial surface is just stripped off from the underlying connective tissue and shows bleeding surface. Okay, the gingival tissues, because of detachment from the underlying connective tissue, show extreme bleeding, extremely sensitive, and it's extremely painful condition, and the patient individual is just unable to eat, swallow anything, and extensive pain and hemorrhage are present. Excessive bleeding is also seen. The treatment for this condition is identifying the underlying hormonal disturbance or underlying dermatologic disturbance and treating accordingly. Steroidal therapy may also be indicated sometimes. Gingival abscess is nothing but an acute localized collection of pus in the gingiva. It is of acute onset, it is of insidious onset, and denotes the collection of pus in the gingiva. What is the etiology for gingival abscess? Etiology is nothing but the penetration of sometimes during invigorous brushing or forceful brushing, if the bristles of gingiva just penetrate deeper into the gingival sulcus, they cause some form of irritation to the gingival sulcus, leading to the development of pus or abscess. What happens is, whenever you are just penetrating the bristles or some material deeper into the gingival sulcus, they tend to carry bacteria with them into the gingival sulcus. Once the bacteria reach the gingival sulcus, it just proliferates, inflammation starts, invariably leading to production of pus. Okay. Or sometimes food material or a foreign object may also get implanted into the gingival sulcus. So gingival sulcus, it is a very painful in origin, it is acute in origin, it is of a sudden onset. Initially, the abscess was limited just to the marginal gingiva, and once the inflammation has progressed to the point of abscess formation, clinically you can just see a swelling visible on the marginal gingiva, and pus exudes from the gingival surface. The swelling may be localized to marginal gingiva, or it may also include the attached gingiva, and it may be red, smooth, shiny because of inflammation, and it is a smooth surface only, and the pus, it just discharges onto the surface. So here you can see in the clinical picture, that is the appearance of a pus, appearance of a gingival abscess, which is just limited, which is just seen in the interdental papilla region. Okay. And treatment for gingival abscess is nothing but if you just insert a probe parallel to the direction of the long axis of the teeth, it leads to expulsion of pus. Once the pus is released, there is reduction of the symptoms, reduction of swelling is seen. When you see the microscopic picture, it's one of an inflammation. Inflammatory cells are present, the capillaries are enlarged, and the edema and formation of an abscess cavity is seen, which is just lined by a wall, and there is diffuse infiltration of polymorphonuclear leukocytes, lymphocytes and plasma cells. Treatment for gingival abscess is nothing but spontaneous rupture. So once you insert a probe into the gingival sulcus, it exudes or releases the pus from the interdental surface or the surface of the gingival abscess, and just leads to reduction in the clinical symptoms. Okay. Now we'll see the gingival enlargements. So why gingiva is enlarged? Gingiva is enlarged normally because of either the inflammatory process or any of the following etiological factors. Normally the gingiva, the marginal gingiva, the attached gingiva is present, and the interdental papilla just fills out between the interdental surfaces of the teeth. So that denotes the healthy periodontium or the healthy gingiva. So in presence of inflammation or any etiological factors, if the gingival surfaces, the marginal gingival surfaces, the attached gingiva and the interdental papilla, they just become enlarged, they become inflamed. If they become enlarged to such an extent, they even cover the occlusal surfaces or the buccal surfaces of the teeth. That is denoted by the term gingival enlargement. Initially, it was called as a hyperplasia, that is a gingival hyperplasia. But it is not an individual cell hyperplasia, but overall the gingiva itself is showed enlarged. And most of the time the gingival enlargement is because of some fibrosis occurring, edema and fibrosis occurring in the gingiva. So we'll see the inflammatory gingival enlargement, the drug-induced gingival enlargement, enlargement associated with systemic diseases, the condition enlargement, that is enlargement due to systemic diseases, or the idiopathic gingival enlargement, neoplastic enlargement, and the false enlargement. Okay, inflammatory enlargement, as we always know that once the marginal gingivitis begins, it proceeds to chronic gingivitis, and in extreme cases it goes to chronic hyperplastic gingivitis, and ultimately chronic enlargement occurs, gingival enlargement occurs. It begins with the gingivitis only. So etiological factors include the poor oral hygiene, the accumulation of dental calculus or mouth breathing. All these correspond to predisposing factors or the etiological factors. Once the inflammation is already present, and on part of that the individual is not maintaining his oral hygiene and he has a mouth breathing habit, it just predisposes to extreme dryness of the oral cavity. The inflammation just progresses to the extent of enlargement. So the clinical appearance of inflammatory gingival enlargement, as you can see in the clinical picture, the interdental papillae become bulbous in nature, they just becomes enlarged, soft, shiny, smooth in nature, they become reddish in color or deep reddish in color, and hyperemic in nature. They are extremely sensitive to touch, very painful gingiva, they just bleed when you touch the gingival surfaces. So this gingival enlargement is not confined just to the buccal mucosa, even the lingual mucosa shows the gingival enlargement. Okay, lingual, alveolar mucosa, all of the oral cavity shows the enlargement. So these gingiva, this enlarged gingiva, they are very sensitive, they just bleed on touching, they bleed easily, and they present a glossy and a non-stipple surface. Drug-induced gingival enlargement, as we know, a lot of patients are under the use of this anticonvulsants, immunosuppressants, and calcium channel blockers. They are using these medications for the systemic conditions, for treating the systemic conditions. Invariably, these drugs, they manifest a side effect of gingival enlargements. So in case of anticonvulsants like diphenyl hydantoin, or calcium channel blockers, or nifedipine, immunosuppressants like cyclosporins, what happens is there is an underlying proliferation of the fibroblast occurring because of some mutation when these drugs are taken systemically. So the proliferation of fibroblasts leads to fibrosis of the gingivae. The fibroblasts become increased in number, they just cause the fibrosis of gingiva and extreme enlargement. So this drug-induced gingival enlargement, initially it begins as a painless enlargement of gingiva involving the interdental papillae, alveolar gingiva, marginal gingiva. Initially the interdental papillae shows the change, then it progresses to involve the other buccal mucosa also. So once the inflammation progresses, normally there is loss of stippling in case of inflammation, but here in drug-induced gingival enlargement, you see the stippling is increased because of excessive fibrosis, and the surface becomes roughened or pebbled. So the difference between the chronic gingivitis and the gingival enlargement is the appearance of the surface. Chronic gingivitis just manifests as a smooth or a shiny surface, but gingival enlargement, because of extreme fibrosis, it appears pebbled or roughened surface. And the gingival tissues are dense, resilient, and they are insensitive because this enlargement is occurring because of proliferation of fibroblasts. Because of some systemic drugs, they are insensitive and they do not bleed. And there is no change in color. In fact, it appears to be little bit paler in color. Okay, idiopathic gingival enlargement, it's also known by the names fibromatosis gingivae or elephantiasis gingivae. So what happens is sometimes the gingiva just become enlarged without any obvious cause. Both the children and the young adults may be affected when before the deciduous teeth erupt, or at the time of eruption of deciduous teeth, the gingiva sometimes become dense, fibrous in nature. It is extremely resistant, and it shows the teeth just do not erupt into the oral cavity. Okay, the large masses of dense, firm, resilient tissue just cover the alveolar ridges, and they are normal in color. In children, what happens is when the gingivae are such largely covered, the lips appear to be protruding, the occlusal surfaces, the incisal surfaces of the crown or teeth are just covered by this fibrous overgrowth. Even a lot of teeth are unerupted, even the deciduous teeth are not erupted. Okay, when you see the microscopic picture of such an enlarged gingiva, it shows there is a hyperplastic epithelium, there is elongation of reiterated hyperkeratosis is present, and when you see the connective tissue, presence of abundant fibroblasts and the mature fibrous connective tissue is common finding. Hormone related enlargement, we have seen that in pregnancy there is an altered immune response because of even presence of a minor local factors, because of extreme hypersensitivity in endocrine response, that is the pregnancy. Even minor local irritating factors present a non-specific inflammation or acute features of chronic inflammation, that is the pregnancy gingivitis. Sometimes a mass like a growth is seen in the gingiva, that is the pregnancy tumor. So inflammatory gingival enlargement or a hormone related gingival enlargement may be seen both in men and women at the time of puberty, as we have already discussed, or owing to this altered immune response, that is endocrine response. Along with that, if poor nutrition, poor maintenance of oral hygiene and local irritating factors are present, this leads to aggravating the disease. Okay, increased levels of estrogen and progesterone in pregnancy, what they cause is they lead to changes in the vascular permeability of the blood vessels. Okay, that leads to edema and ultimately fibrosis of the gingiva occurs. This fibrosis it should regress once in the last trimester of pregnancy or after termination of pregnancy. Sometimes it just remains. When it remains, you just have to carry out a gingivectomy or a gingivoplasty procedure to recontour the gingival surfaces. Usually it just regresses. Okay, nutritional deficiency enlargement, most commonly associated with the vitamin C deficiency. We know in vitamin C is required for the maintenance of collagen tissue in the gingiva. So whenever this is deficient, it leads to scorbutic gums, as we call. The gingiva becomes swollen, tender, edematous, red or purple, just bleed easily, and in extreme cases ulceration and necrosis of interdental papillae is also seen. Treatment includes, you have to identify the nutritional deficiency and just administer vitamin C supplements, or intake of vitamin C just leads to regression of this condition. Allergic enlargement is also known as a plasma cell gingivitis or atypical gingivitis. Actually, individual manifest some form of allergy to any component present. So as a dentist, you will be prescribing a lot of mouthwashes or toothpaste or any substance to be applied locally in the oral cavity. Sometimes few of the individuals may just be allergic to that particular component of the chewing gum or mouthwash, and they manifest a hypersensitive reaction to that component, and clinically they show the appearance of gingivitis and gingival enlargement. So this allergic enlargement is most commonly seen in young women. Initially it begins with the soreness of the mouth. So the patient complains of inability to take hot or spicy food. Once the marginal gingivitis begins and the disease progresses, it becomes marginal enlargement. So the gingiva again becomes swollen, edematous, with loss of stippling because of underlying inflammation. When you see the microscopic picture of allergic enlargement, it shows that the surface epithelium is hyperplastic, and epithelium shows hyperkeratosis also. The presence of inter and intercellular edema and micro abscesses is common. When you see the connective tissue, it shows presence of the chronic inflammatory cells and the polyclonal mixture of plasma cells, and the vascular capillaries, whatever are present, they are just engorged and appear to be edematous, and thus the marked vascular dilatation appears. Treatment for this is identifying the component or the etiologic factor and just withdrawing it from your diet or intake just leads to regression of this condition. Most commonly, the fibrosis of gingivae or fibrous enlargements, they are due to some etiological factors only. If you just remove the etiological factors, you see that the fibrosis regresses on its own within a span of few days. Even in drug-induced enlargement, whenever the drug is withdrawn from our intake, the fibrosis or the fibrous enlargement just regresses. Okay. Sometimes, what the conditioned enlargement occurs. Conditioned enlargement is nothing but enlargement of gingiva owing to some specific conditions of the oral cavity. So, in case of few systemic diseases, like leukemia, acute myelomonocytic, acute lymphoblastic, or the chronic leukemias, what happens is there is increase in the number of lymphocytes or leukocytes. So that leads to this enlargement of the gingiva. So the leukemic enlargement, it may be diffuse. It involves the buccal mucosa, the lingual mucosa, alveolar mucosa, the whole of gingiva, marginal, attached, all. So what happens is, whenever the gingiva is enlarged, it appears as shiny, reddish or bluish red. It is edematous, it is soft, it is just compressible. Whenever you see the gingival enlargement and you just compress with the finger, it is very soft and it just gets compressed, and it is very, very tender, and frequently sometimes it shows ulceration, and there are absence of stippling because of underlying inflammation present here. Okay. In leukemia, we know there is increase in number of lymphocytes or leukocytes. Along with that, there is increased deposition of or infiltration of lymphocytes into the gingiva occurs, leading to this conditioned gingival enlargement. When you see microscopic picture of leukemic gingival enlargement, you see the presence of immature leukocytes based on the type. Based on the acute myelomonocytic type, you can see the myelomonocytes will be seen. Based on the type, you can see the presence of immature leukocytes, and the capillaries are just enlarged, engorged, and the connective tissue, it appears edematous in nature. So now we'll see the periodontitis. Periodontitis, it is an inflammatory disease of the periodontium or the supporting tissue caused by a group of organisms or a specific organisms. Ultimately, it results in destruction of the periodontal ligament, alveolar bone due to pocket formation, or it causes destruction of both the periodontal ligament or the alveolar bone, or the gingival recession also. So we'll see the chronic forms of periodontitis, the aggressive periodontitis, and their effects on the oral cavity. Okay, the chronic periodontitis, it is the most commonest form of periodontitis seen in oral cavity. It is also known as pyorrhea. Okay, it is most common seen in adults. Initially, what happens is, any inflammation, it begins as a gingivitis initially. Once the chronic gingivitis is present for a decade or so, due to alteration in the microorganisms or due to extreme exaggeration of the inflammation, this gingivitis, it just progresses to periodontitis. It leads to loss of attachment, loss of alveolar bone, and ultimately periodontal loss. Okay, bone loss. So, gingivitis should precede the development of periodontitis. Okay, it may not be noticed by the patient. The gingivitis may not be noticed by the patient. The patient may present you with a complaint of mobile teeth, but etiological factor, that is the gingivitis, will definitely precede. And local factors, again acting as irritating factors, are the same: the microbial plaque, the calculus, the food impactions, and the irritating fillings or restorations. So initially it begins as a simple marginal gingivitis. Once it reaches the clavicular epithelium becomes ulcerated, inflamed, edematous The gingiva becomes more inflamed and there is change in color of the gingiva from light pink to deeper hue of pink. The epithelial attachment, normally the epithelial attachment or the junctional epithelium is just snugly fixed around the tooth, okay, but because of the inflammation progressing to the involve the epithelium, the clavicular epithelium, it just migrates apically to the surface of teeth, leading to the development of clinically long crowns, that is the gingival recession, and even the attachment just separates, there is loss of attachment from the root surface of the tooth, leading to pocket formation. Okay, the gingival crevice normally just 1 mm, it just becomes deeper because of the loss of attachment, and ultimately it leads to pocket formation. Okay, these gingiva, they bleed readily because of the underlying inflammation, and minute spontaneous hemorrhages may be present because of extensive food accumulation in the pockets, and even in the interdental spaces, or in the because of the receded areas, there is a lot of food accumulation, there is a lot of calculus accumulation, it leads to halitosis also. Okay, ultimately pocket formation occurs because of both the apical migration of epithelial attachment and loss of attachment from the root surface of the teeth. Microscopically, this presents as an inflammatory condition of gingiva, marginal gingiva, it is just infiltrated with lymphocytes and plasma cells. Ultimately, as the inflammation progresses, initially there is osteoclasts begin to appear on the alveolar surface of bone. Okay, on the crest of alveolar bone, osteoclasts appear. These osteoclasts appear to lie in the Hauschiff's lacunae. Once the inflammation starts, the osteoclasts are activated and they just lead to resorption of the bone. Okay, and based on the presence of the loss of attachment, based on the presence of the periodontal pocket, the periodontium is divided into different types. That is, if the whatever pathologic changes are seen in chronic periodontitis, if they are limited just to the gingiva, it is called as a gingival pocket or a pseudo pocket. If the base of the pocket has further invaded into the periodontium, about more than 3 to 4 mm of gingival sulcus or crevice is seen, that denotes a periodontal pocket. If the depth of the pocket, it extends apically beneath the crest of the alveolar bone, it is called as a infrabony pocket. It is usually surrounded by a bone on its lateral wall only. When you see the radiographic pictures of a chronic periodontitis, you see that initially there is just blunting of the alveolar crest, that is there is surface erosion of the alveolar bone is seen, crest, then as the osteoclasts are activated, bone loss is seen. This bone loss is horizontal in cases of chronic periodontitis. Okay, and the interdental papillae, usually it appears to be a sharp triangular, it just becomes flat or cupped in nature. Treatment for treatment for maintaining the gingiva, maintenance of the gingival health is, first you have to just release the periodontal pocket. You have to just exclude the periodontal pocket by gingivectomy. In cases of, so once if you cause a recession to happen, then at a later stage, if all the irritating factors, the calculus, the food impactions are all under control, the gingiva just gains reattachment to the surface of teeth. So that's about the chronic periodontitis. Aggressive periodontitis, basically it's a rapidly progressive type of periodontitis that occurs in patients who do not have calculus and plaque. So that's the difference between the chronic and aggressive periodontitis. Chronic periodontitis, it occurs in individuals who had definite etiologic factors. But in aggressive periodontitis, previously it was called as a juvenile aggressive periodontitis, seen in both children and adults like that. But now the term juvenile is obscure, only the term aggressive periodontitis or rapidly progressive periodontitis is used here. Despite the absence of etiologic factors, there appears to be defect in immune response and the specific characteristic microorganism, that is the actinobacillus, actinomycetum comitans and the Porphyromonas gingivalis, both of these have caused a non-specific immune response. There are two forms of aggressive periodontitis. There is a localized form and a generalized form. Localized form of aggressive periodontitis, it is usually seen in around puberty. And the localized form, it's given the name that it affects basically the two teeth. It involves the two teeth, and those two teeth are nothing but our incisors and the first molars. So both of them should show the loss of attachment and bone loss, incisors and first molars. Okay. So there is no clinical inflammation because of absence of the etiological factors. There is the calculus and the plaque, and bone loss is confined to incisors and first molars. And obviously, because of loss of attachment, there is a deep periodontal pocket. Okay. Whereas the generalized form, it involves the loss of attachment involving two or more teeth. Basically three teeth should be involved other than the incisors and molars. So it includes the generalized form of aggressive periodontitis, which is usually seen under 30 years of age, that is middle-aged individuals, and it is been associated with accumulation of plaque calculus, because it is a generalized form, right? It involves more than three, and because of pocket formation, obviously there will be deposition of food debris, accumulation of plaque calculus occurs invariably and leads to further progression of inflammation. Okay, when you see the radiologic picture, the localized form, it shows the arch-shaped bone loss which is confined to incisors and molars. Okay, that is nothing but a vertical loss of alveolar bone. Generalized form, minimum three teeth should show vertical bone loss. Management for aggressive periodontitis is nothing but scaling, root planing initially, and then pocket elimination procedures have to be carried out. Gingivectomy may be carried out, and antibiotics are given systemically and topically to control the microbial infection, and mechanical removal of plaque and calculus is carried out. Sometimes flap surgeries have to be carried out in individuals, and systemic antibiotics are of more use in case of aggressive periodontitis. Okay, there is another syndrome known as Papillon-Lefevre syndrome. It is basically familial in nature. It's transmitted as an autosomal recessive disorder. It is one of the manifestations of Papillon-Lefevre syndrome is the occurrence of aggressive periodontitis. Okay, basically this Papillon-Lefevre syndrome shows characteristic skin changes. There is the palmoplantar keratosis. Along with that, presence of aggressive periodontitis, localized or generalized form is characteristic. So there is rapid bone loss, the teeth become mobile, tender to percussion, and pathologic migration occurs in such individuals. Necrotizing ulcerative periodontitis. We have seen the acute specific form of gingivitis, that is the necrotizing ulcerative gingivitis, if the gingivitis do not show any attachment loss. So if the gingivitis progresses to involve the periodontium, there is loss of periodontial attachment, and already in individuals affected with acute necrotizing ulcerative gingivitis, there is profound immunosuppression and malnutrition. So all these contribute to this necrotizing ulcerative periodontitis. So the etiological factors may be obviously the Fusobacterium, that is the Borrelia vincenti, along with that Treponema, Porphyromonas intermedia, and other microorganisms are also causative. And the periodontitis is more commonly seen in HIV infected individuals. So whenever the CD4 plus count in HIV affected individuals is below 200 cells per mm3, so obvious necrotizing ulcerative periodontitis will be a clinical manifestations. This general systemic, and this affects very younger individuals, about 20 years of age, and general systemic manifestations of fever, malaise, and lymphadenopathy are seen. Along with that, the hyperemia of papillae, the sharply punched out crater-like lesions as seen in necrotizing ulcerative gingivitis, they just progress to involve all of the alveolar mucosa, and ulceration and necrosis of gingiva invariably occurs, and the gingiva are very painful, extremely sensitive to touch. Spontaneous bleeding is present, and sometimes because of extreme necrosis and ulceration, the bone of alveolar mucosa just gets exposed to the oral cavity, undergoing rapid destruction. So management includes symptomatic treatment as we have done in the acute necrotizing ulcerative gingivitis, that is installation of oral mouthwashes, mouth rinses, superficial cleansing of the oral cavity with chlorhexidine or peroxide mouthwash, antibiotic dosage is given, and whatever malnutrition or immunosuppressive disease the patient is affecting, that has to be corrected. Okay, so that's about the periodontitis. So the other common abscess which is seen is the lateral periodontal abscess. We have seen in gingival abscess, it is because of bacteria being carried to the gingival sulcus, or some form of irritation giving rise to the gingival sulcus. The lateral periodontal abscess also occurs because of some form of foreign body being carried to the periodontal region, that is the in the pocket depth. What happens is, once the gingivitis progresses to periodontitis, there is formation of a periodontal pocket, and because of some reasons, the occlusal surface of the periodontal pocket is just occluded. Okay, the occlusal surface is just occluded, though there is underlying pocket, that is a pseudo pocket is present. The orifice of the pocket is occluded by some food or some restoration, and the underlying pocket is present, the periodontal pocket is present, and if there is deposition of microorganisms or food materials, obviously microorganisms will be present in the periodontal pocket, so that leads and the orifice is just closed, so it forms a focal area of suppuration, focal area of inflammation. The inflammation just progresses with rapid development of polymorphonuclear leukocytes and all, suppuration and abscess formation occurs. That's nothing but a lateral periodontal abscess. It occurs basically in adults, and the tooth is tender to percussion, and clinically the patient complains of a pain. The area is extremely sensitive to touch. There is mobility of the involved tooth, and pus releases from the neck of the tooth surface, and the patient complains of a foul taste. So whenever you see microscopic picture, it's appearing of one of an abscess. There is a central pus-filled cavity will be present, which is surrounded by root on the one side, and the other side it is shown by connective tissue. The connective tissue shows inflammatory cells, polymorphonuclear leukocytes predominate. And the treatment for this includes direct incision on the periodontal pocket. It leads to rapid expulsion of the pus, or if you insert a periodontal probe and the periodontal pocket, it also leads to expulsion of the pus.